Delayed respiratory depression can occur with less lipid-soluble drugs, particularly morphine. 7. Risk factors for respiratory depression: increasing patient age, high doses of opioid, concurrent use of sedatives and systemic opioids. 8. Diamorphine offers best combination of duration of analgesia with fewest side effects. Malignant hyperthermia. Cyprian Mendonca, a 9-year-old girl undergoing correction of scoliosis, develops tachycardia during the procedure. What are the causes of tachycardia? Causes of intraoperative tachycardia. 1. Inadequate analgesia, often associated with hypertension. 2. Inadequate depth of anesthesia, usually associated with hypertension, sweating and lacrimation. 3. Muscle relaxation wearing off. There are other signs such as breathing against the ventilator, high airway pressure and inspiratory efforts seen on the capnograph trace. 4. Hypovolemia. This is usually due to blood loss. A rapid assessment of blood loss in the suction and surgical field and the amount of fluid administered will aid in the diagnosis. 5. Hypoxia. A systematic approach to checking the inspired oxygen concentration, FGF, and patency of airway will aid in the management. 6. Hypercarbia. This may be due to hypoventilation or to increased CO2 production. 7. Drugs. Accidental or therapeutic administration of anticholinergic drugs or catecholamines can cause tachycardia. Anaphylaxis to drugs may manifest as tachycardia. 8. Surgical stimulation. 9. Malignant hyperthermia MH. Increasing ECO2 despite adequate ventilation and rapidly depleting carbon dioxide absorber may suggest the diagnosis. Despite correcting all possible causes, tachycardia persists and the ECO2 increases. What is the most likely diagnosis? Malignant hyperthermia is the most likely diagnosis. How would you manage a malignant hyperthermia crisis? Turn off the vaporizer and use high FGF and hyperventilate with 100% oxygen. Call for help. Stop the surgery if possible. Maintain anesthesia with an intravenous propofol infusion. Monitor temperature and start active body cooling measures. Administer dantrolene 2-3 mg/kg IV initially and then repeat with a dose of 1 mg/kg until CO2 production, tachycardia and temperature are controlled. Monitor arterial blood gases, invasive blood pressure, central venous pressure, urine output, hematocrit, platelets, clotting screen and creatine kinase, peaks at 24 hours. Acidosis should be treated with sodium bicarbonate and hyperventilation. Hyperkalemia should be treated with sodium bicarbonate, calcium chloride and dextrose insulin infusion. Forced alkaline diuresis. Aiming for a urine output of 3 ml/kg and a urine pH of 7.0 in order to treat myoglobinemia. Disseminated intravascular coagulation DIC should be treated with FFP, cryoprecipitate, and platelets. Cardiac arrhythmias should be treated with magnesium and amiodarone. Calcium channel blockers should be avoided. Once the vital parameters are stable, continuation of the surgery may be considered, and post-operatively the patient should be transferred to the ICU. Late management involves counseling the patient and family regarding the implications of MH and referring the patient to an MH unit for investigation. How would you confirm the diagnosis of MH? MH is mainly diagnosed by in vitro contracture testing, INVCT. Fresh muscle strips should be taken from the patient's vastus muscle under local anesthesia. The test involves exposure of muscle strips to halothane and caffeine and measuring the tension generated in the muscle. Muscles from MH-susceptible patients develop higher tension at lower concentrations of halothane and caffeine compared with normal individuals. DNA testing can be used to complement INVCT. DNA should be screened for mutations in the ryanodine receptor protein gene. If the mutation is not present, diagnosis of MH cannot be rejected. Diagnosis should be confirmed by muscle biopsy. What anesthetic agents trigger MH? Triggering agents include all volatile anesthetics, halothane, enflurane, isoflurane, sevoflurane, desflurane, and the depolarizing muscle relaxant, succinylcholine. What is the pathogenesis of MH? Volatile anesthetics and/or succinylcholine cause a rise in the myoplasmic calcium concentration. The rise in calcium concentration leads to an activation of actin and myosin filaments and explains the rigidity and the masseter spasm. one of the early signs of MH. The raised calcium concentration further leads to stimulation of the energy-consuming processes in the skeletal muscle, leading to metabolic acidosis. There is uncontrolled oxidative phosphorylation. The hypermetabolism seen in MH leads to several clinical signs, such as hypertonia, arrhythmia, tachycardia and hyperthermia. Acidosis results from excessive production of CO2 and lactic acid. Rhabdomyolysis occurs as a result of excessive contractile activity. Laboratory findings include hyperkalemia, raised creatine kinase and myoglobinuria. There is a statistically significant association between inheritance of DNA markers for ryanodine receptor protein and MH susceptibility in 60% families. Ryanodine, an alkaloid, binds selectively to the ryanodine receptor, a calcium channel in the sarcoplasmic reticulum. In some families with MH predisposition, no ryanodine receptor defect has been isolated. Because of this heterogeneity, it is difficult to diagnose MH based on genetic testing. What other conditions are associated with MH? Central core disease and inherited forms of peripheral muscle weakness are associated with MH. Several other neuromuscular diseases and heat stroke may be associated with MH. Although true association with these conditions has not been confirmed, clinical presentation of malignant hyperthermia MH is an acute pharmacogenetic disorder, with autosomal dominant inheritance. Both genetic predisposition and one or more triggering agents are necessary to evoke MH. The prevalence of the genetic MH predisposition is between 1,5,000 to 1,10,000. The incidence of reported MH reactions varies from 1 in 40,000 to 1 in 100,000. Anesthetics. MH has a wide spectrum of presentation: muscle rigidity after succinylcholine. This can be isolated masseter spasm or generalized rigidity. Masseter spasm associated with grossly elevated creatine kinase and myoglobin increases the likelihood of MH. Classical MH crisis. Apart from masseter spasm, the two most important clinical features are an unexplained increase in ECO2 and tachycardia due to hypermetabolism. Later, a rise in body temperature can occur which can exceed a rate of more than x31 degrees Celsius per 10 minutes. Eventually, because of extensive cellular damage, hyperkalemia, acidosis, increased plasma creatine kinase and myoglobinuria ensues. Arrhythmias and DIC are other features. Other miscellaneous presentations include postoperative acute renal failure due to myoglobinuria, unexpected cardiac arrest or even death. The differential diagnosis of MH includes thyroid storm, pheochromocytoma, infection and sepsis. In a patient with suspected MH who presents for surgery, avoid all triggering agents and use total intravenous anesthesia. Consider regional anesthesia if feasible. Use a vapor-free anesthetic machine. With the above measures, prophylactic dantrolene is not necessary. If a vapor-free anesthetic machine is not readily available, it can be prepared by the removal of vaporizers and flushing through the machine and ventilator with 100% oxygen at maximal flow for about 20-30 minutes. All intravenous anesthetics, including ketamine and benzodiazepines, are safe, as are all analgesics and non-depolarizing muscle relaxants. Nitrous oxide also has been safely used. Other drugs which can be used include local anesthetics, neostigmine, atropine and glycopyrrolate. Key points: masseter spasm and muscle rigidity following succinylcholine is one of the early signs of malignant hyperthermia. Malignant hyperthermia should be suspected in the presence of unexplained tachycardia and increasing ECO2. The diagnosis of malignant hyperthermia is confirmed by in vitro contracture testing, esophagectomy procedure Oxford. 1. Total or partial excision of esophagus with mobilization of stomach occasionally colon, into chest. 2. Time, 3 to 6 hours. 3. Pain, severe. 4. Position, supine with arms by sides and or lateral decubitus for thoracotomy. 5. Blood loss, 500-1500 milliliters, cross-match 2 units. 6. Practical techniques: IPPV, OLV via DLT or bronchial blocker, arterial and CVP lines, urinary catheter, thoracic epidural or paravertebral catheter for thoracoabdominal incision. Types of procedure: 1. Minimally invasive, thoracoscopic esophageal mobilization, laparoscopic gastric mobilization and cervical anastomosis. 2. Ivor Lewis, laparotomy and right thoracotomy, often laparoscopic assisted. 3. Transhiatal, laparotomy and cervical anastomosis. 4. Thoracoabdominal, left thoracotomy crossing the costal margin and diaphragm. 5. McEwen 3-stage, laparotomy, right thoracotomy and cervical anastomosis, preoperative. 1. Establish indication for surgery, esophageal cancer, benign stricture, achalasia. 2. Preoperative malnutrition or cachexia is common and associated with higher risk of postoperative morbidity and mortality. 3. Preoperative adjuvant chemotherapy may leave residual immunosuppression but can improve dysphagia. 4. Some centers utilize enhanced recovery protocols. 5. Will need HDU or ICU, depending on local protocols. Perioperative, consider all patients with esophageal disease to be at risk of regurgitation. Some patients may require a modified RSI if thoracotomy is planned. Use a DLT or bronchial blocker. Prepare for long surgery, sometimes involving repositioning. Multimodal analgesia is necessary, including regional block. NSAIDs should be avoided, but give intraoperative paracetamol and magnesium. Consider clonidine, and for shoulder tip pain, tramadol. Plan regional anesthesia according to the surgical approach. Paravertebral catheter infusion with morphine PCA for the thoracoabdominal approach. For laparotomy thoracotomy, a mid-thoracic epidural is advised for intra and postoperative use. An NGT will be required initially. It is removed for resection and reinserted under surgical guidance following anastomosis. Monitor the core temperature, and be obsessional about keeping the patient warm. A fluid restrictive regime is advised, typically 2 ml kgh as an infusion, with additional fluid boluses as guided by hemodynamic parameters for hypovolemia. Vasopressors should be used where required. Check HB and blood gases regularly. Arrhythmias and reduced CO causing hypotension may occur during intrathoracic esophageal mobilization. Change the DLT to an SLT to improve surgical access prior to cervical anastomosis, if performed. Postoperative, early extubation is ideal if cold, 35.5 degrees C, or hemodynamically unstable. Ventilate until the condition improves. Patients require intensive and experienced postoperative nursing care in a specialist ward, HDU or ICU. Use a jejunostomy or nasoduodenal tube for early enteral feeding. A bridle can be useful in these patients who are prone to postoperative delirium. Special considerations: oesophageectomy has one of the highest perioperative mortality rates of all elective procedures, up to 5%, even in specialist centers. 66% of deaths are from systemic sepsis 2 degrees to respiratory complications or anastomotic breakdown. Over 30% of patients suffer a major complication. The majority of centers perform minimally invasive, endoscopic oesophageectomy. Beware, tension capnothorax if the pleura is breached during laparoscopic hiatal dissection. Occasional practice in anesthesia or surgery for oesophageectomy is not recommended. Laboratory evaluation for intravascular volume. Laboratory measurements can indicate intravascular volume and tissue perfusion, including serial hematocrits, arterial blood pH, urinary specific gravity or osmolality, urinary sodium or chloride concentration, serum sodium and BUN2. Serum creatinine ratio. However, these measurements are indirect and affected by perioperative factors. Signs of dehydration may include increasing hematocrit and hemoglobin, metabolic acidosis, high urinary specific gravity and osmolality, low urinary sodium, hypernatremia, elevated BUN to creatinine ratio. Note that hemoglobin and hematocrit may not change in acute hypovolemia due to blood loss. Imaging studies like ultrasonography and radiography can also indicate volume status. Hemodynamic measurements. Hemodynamic monitoring is used to assess volume status, especially when difficult to evaluate by other means. Central venous pressure, CVP monitoring has limitations, as single readings do not accurately indicate volume status. Pulmonary artery pressure monitoring is used when CVP readings are unclear or in patients with right ventricular dysfunction. Pulmonary artery occlusion pressure, PAOP. PAOP should be obtained at end expiration. Normal values are typically less than 15 mmHg, readings less than 8 mmHg. Hypovolemia in patients with normal left ventricular compliance. Values greater than 18 mmHg are elevated and may imply left ventricular volume overload. Non-invasive assessments, such as arterial pulse contour analysis, esophageal Doppler, and echocardiography, can provide more accurate estimates of cardiac filling and function. V-stroke volume variation SVW can predict responsiveness to fluid therapy, with normal SVV being less than 10 to 15%. V non-invasive modalities are preferred over invasive catheters due to reduced risks. Fluid responsiveness. 1. Defined as the ability of the heart to increase stroke volume in response to volume expansion due to biventricular preload reserve. 2. Static marker CVP, PAO, cardiac chamber dimensions poorly predict fluid responsiveness. 3. Dynamic markers, a heart-lung interaction index is validated in patients receiving full mechanical ventilation, respiratory variation of arterial pulse pressure, peak Doppler aortic blood velocity, descending aorta blood velocity, or blood flow, pulse contour-derived stroke volume variation, B. Passive leg raising, PLR, increases preload by gravitational transfer of blood from lower limbs, detects increase in cardiac output using real-time monitor. Limitations. 1. Heart-lung interaction index is not applicable in spontaneously breathing patients, tidal volume 7 ml/kg, patients with arrhythmias. 2. PLR can accurately detect fluid responsiveness in patients with spontaneous breathing activity and/or cardiac arrhythmias. Intravenous fluids. 1. Crystalloids, aqueous solutions of ion salts, with without glucose, distribute throughout the extracellular fluid space. 2. Colloids, contain high molecular weight substances, maintain plasma colloid oncotic pressure, and remain mostly intravascular. 3. Debate, long-standing controversy between colloid and crystalloid use in surgical patients. 4. Colloid benefits, more efficient in restoring intravascular volume and cardiac output, requiring smaller volumes. 5. Crystalloid benefits, equally effective in large enough amounts, less expensive. 6. Key differences, crystalloids require 3-4 times the volume of colloids to achieve the same effect. Colloids better for rapid correction of severe intravascular fluid deficits. Surgical patients may have an extracellular fluid deficit that exceeds the intravascular deficit, making crystalloids potentially more suitable for addressing this issue. Excessive crystalloid administration, 4-5L, can lead to tissue edema, impairing oxygen transport, tissue healing, and increasing infection risk. 7. No clear preference. Both crystalloids and colloids have their advantages and disadvantages, and the choice between them depends on the specific clinical situation. Crystalloid solutions. Types of crystalloid solutions. 1. Isotonic solutions, normal saline, lactated Ringer's solution, and plasmolite. These solutions are used to replace isotonic fluid losses. 2. Hypotonic solutions, used to replace pure water deficits, but must be administered slowly to avoid hemolysis. 3. Hypertonic solutions, 3% saline, used to treat severe, symptomatic hyponatremia. 4. Glucose-containing solutions, used to maintain tonicity, prevent ketosis, and hypoglycemia. Preferred solutions. 1. Balanced electrolyte solutions, lactated Ringer's solution or plasmolite, preferred for most perioperative uses. 2. Normal saline, preferred for correcting hypochloremic metabolic alkalosis and diluting packed red blood cells. Considerations. 1. Hyperchloremic metabolic acidosis, normal saline can cause this when given in large volumes. 2. Perioperative acute kidney injury, chloride-rich crystalloids like normal saline may contribute to this. 3. Hypoglycemia, children prone to developing hypoglycemia during fasting. Colloid solutions, indications for colloids. 1. Fluid resuscitation in patients with severe intravascular fluid deficits, e.g., hemorrhagic shock. 2. Fluid resuscitation in patients with severe hypoalbuminemia or large protein losses, e.g., burns. 3. Considered for use in conjunction with crystalloids when fluid replacement needs exceed 3-4 L prior to blood transfusion. Types of colloid solutions. 1. Blood-derived colloids, albumin 5% and 25% solutions, and plasma protein fraction 5% solution. 2. Synthetic colloids, gelatins, dextrin, and hetastarch. Important considerations. 1. Colloid solutions can cause hyperchloremic metabolic acidosis. 2. Colloids have a longer intravascular half-life 3 to 6 hours, compared to crystalloids, 20 to 30 minutes. 3. Dextrin can interfere with blood typing and may prolong bleeding time. 4. Hetastarch can decrease von Willebrand factor antigen levels and may prolong the prothrombin time. 5. Both dextrin and hetastarch are potentially nephrotoxic and should be used with caution in patients at risk for acute kidney injury. 6. Plasma protein fraction can cause hypotensive allergic reactions, especially with rapid infusion, 10 ml min. 7. Gelatins are associated with histamine-mediated allergic reactions. 8. Dextrin and hetastarch can cause anaphylactoid and anaphylactic reactions. Specific guidelines. 1. Dextrin, avoid infusions exceeding 20 ml/kg per day. 2. Hetastarch, avoid use in patients with a history of kidney disease or at risk for acute kidney injury. 3. Albumin and plasma protein fraction, heat to 60 degrees Celsius for at least 10 hours to minimize the risk of transmitting hepatitis and other viral diseases. Perioperative fluid therapy, normal maintenance requirements, pre-existing deficits. 1. Patients fasting overnight 8 to 12 hours can have a pre-existing fluid deficit of approximately 880 milliliters. 2. The deficit can be estimated by multiplying the normal maintenance rate by the length of the fast. 3. However, the actual deficit is often less due to renal conservation of fluids. 4. Current anesthesia practice may allow oral fluids up to 2 hours before surgery, minimizing the pre-existing deficit. 5. Abnormal fluid losses can contribute to pre-existing deficits, including preoperative bleeding, vomiting, nasogastric suction, diuresis, diarrhea, fluid sequestration by traumatized or infected tissues, coagulopathy, related occult hematoma formation, ascites, increased insensible losses due to hyperventilation, fever, and sweating. 6. Ideally, pre-existing deficits should be replaced preoperatively with fluid similar in composition to those lost. Surgical fluid losses, blood loss. 1. Estimating blood loss is crucial for guiding fluid therapy and transfusion. 2. Estimation methods include measuring blood in the surgical suction container, visual estimation of blood on surgical sponges, 4x4s, and laparotomy pads, lap sponges. 3. Estimated blood volume in soaked sponges and laps, 4x4 sponge, 10 milliliters, laparotomy pad, lap, 100-150 milliliters. 4. More accurate estimates can be obtained by weighing sponges and laps before and after use. 5. Irrigating solution volume should be subtracted from estimates. 6. Serial hematocrits or hemoglobin concentrations reflect the RBC to plasma ratio, but are affected by fluid shifts and intravenous replacement. Other fluid losses. 1. Surgical procedures can result in fluid losses other than blood, mainly due to evaporation and internal redistribution. Third, spacing. 2. Evaporative losses occur with large wounds, especially burns. 3. Internal redistribution can cause massive fluid shifts in patients with peritonitis, burns, or inflamed infected tissue. 4. Traumatized tissue can sequester fluid, leading to ascites, fluid shift into the bowel, and edema. Intraoperative fluid replacement. Intraoperative fluid therapy aims to meet basic fluid requirements, replace preoperative deficits, and compensate for intraoperative losses, blood loss, fluid redistribution, and evaporation. The type of intravenous solution is guided by the surgical procedure and expected blood loss. For minor procedures, minimal fluid is administered, while for other procedures, a balanced crystalloid, e.g., lactated Ringer's solution or plasma light, is used for maintenance. Goal-directed fluid therapy, GDFT, involves using hemodynamic variables to guide fluid administration and optimize tissue oxygen delivery. GDFT regimens vary, but often include the use of stroke volume, cardiac output, and mean arterial blood pressure to determine fluid responsiveness. GDFT has been incorporated into enhanced recovery protocols, but studies have reported inconsistent results, with some showing fewer postoperative complications and shorter hospital stays. Replacing blood loss. 1. Blood loss should be replaced with crystalloid or colloid solutions to maintain normovolemia until the danger of anemia outweighs the risks of transfusion. 2. There are no mandatory transfusion triggers, and the decision to transfuse must be individualized. 3. A hemoglobin concentration below 7.8 gdl may be considered for transfusion in most patients. 4. Patients with cardiovascular disease may benefit from a higher hemoglobin threshold, e.g., 8.9 gdl transfusion threshold. 5. Patients with a normal hematocrit should generally be transfused only after losses greater than 109% to 20% of their blood volume. 6. In non-trauma settings, lactated Ringer's solution or plasma light may be administered in 3-4 times the volume of blood lost, or colloid in a volume equal to blood loss. 7. Blood is replaced unit for unit with reconstituted PRBCs once the transfusion trigger point is reached. Transfusion decisions are individualized, but generally not recommended until HCT falls to 24% or less, hemoglobin 8.0 gdll. Key considerations include potential for further blood loss, rate of blood loss, and comorbid conditions. Clinical guidelines for RBC transfusions include -1 unit of RBCs increases hemoglobin by 1 gdl and hematocrit by 2 to 3% in adults. 10 ml/kg RBC transfusion increases hemoglobin by 3 gdl and hematocrit by 10%. Emergency transfusion. In life-threatening bleeding, transfusion may occur before cross-match, screen, or typing, if patient's blood type is known. A 5-minute abbreviated cross-match confirms ABO compatibility. If unknown, type ORH negative universal donor, red cells are used. Massive transfusions often follow a 1:1 ratio of RBCS, FFP, platelets, blood storage, CPDA1. Preserved blood can be stored for 35 days. Alternative solutions extend shelf life to 6 weeks. Red cells are stored at -31 degrees Celsius to 6 degrees Celsius or frozen in hypertonic glycerol solution for up to 10 years and contain 259 ml unit. Platelets are stored at 20 degrees Celsius to 24 degrees Celsius for 5 days. 50 ml unit. Plasma is frozen and must be transfused within 24 hours after thawing. 150-200 ml. Plasma is frozen and must be transfused within 24 hours after thawing. 150-200 ml unit. Cryoprecipitate. Contains factor VL and fibrinogen. Stored frozen blood components. 1 unit of whole blood yields approximately 250 milliliters of PRBC. Platelets are obtained from donors by apheresis, with 1 unit equivalent to 6-8 units of whole blood. Leukocyte reduced. Leukoreduction. Blood products reduce transfusion. Related risks. Intraoperative transfusion practices for RBCs. Transfuse as PRBCs to optimize blood bank resources. Use crystalloid or colloid for volume replacement through a separate IV line. Verify each unit against the blood bank slip and recipient's ID bracelet. Use a 170 filter in transfusion tubing to trap clots or debris. Warm blood to 37 degrees Celsius during infusion, especially for multiple units. Failure to warm blood can cause hypothermia and tissue hypoxia due to low 2,3-DPG levels and a leftward shift of the hemoglobin-oxygen dissociation curve. VEFP transfusion contains all plasma proteins, including most clotting factors, indicated for isolated factor deficiencies, reversing warfarin therapy, and correcting coagulopathy and liver disease. Each unit increases clotting factor levels by 2 to 3% in adults. Initial dose 10-15 ml/kg, aiming for 30% normal coagulation factor concentration. Point-of-care coagulation analysis, e.g., TEG, ROTEM, Soniclot, guides FFP and platelet administration, also used in massive blood transfusions, antithrombinil deficiency, and thrombotic thrombocytopenic purpura, carries same infectious risk as whole blood and may cause sensitization to plasma proteins. ABO-compatible units are preferred but not mandatory. FFP should be warmed to 37 degrees Celsius prior to transfusion. Platelet transfusions, indicated for bleeding associated with thrombocytopenia or dysfunctional platelets. Prophylactic transfusions given for platelet counts below 10,000 to 20,000x10-9/L. Transfusions also given before surgery or invasive procedures for counts below 50,000x. 10-9/L. A single unit of platelets increases count by 5,000 to 10,000 x 10-9/L. ABO-compatible platelets desirable but not necessary. Transfused platelets survive 1 to 7 days, with ABO compatibility increasing survival. Risks include Rh sensitization and hemolytic reactions from ABO-incompatible units. Rh immunoglobulin can protect against Rh sensitization. Indications for procoagulant transfusions. Transfusion algorithms guided by laboratory testing reduce unnecessary transfusions. Trauma care units transfuse blood products in equal ratios 1:1:1. FFP, platelets, PRBCS, to prevent or correct trauma-induced coagulopathy. This approach is called damage control resuscitation. Tranexamic acid or epsilon-aminocaproic acid are often given prophylactically to reduce blood loss. Coagulation factor concentrates, e.g., prothrombin complex concentrate, recombinant factor VILA, are used to treat perioperative coagulopathy and hemorrhage when the benefit outweighs any potential increased risk of thrombosis. Transfusion reactions, categorized as hemolytic immune non-hemolytic infectious complications, ahemolytic immune reactions. 1. Acute hemolytic reaction. Hemolytic transfusion reactions occur due to ABO blood incompatibility, often caused by misidentification. Symptoms include chills, fever, and pain in awake patients, and hypotension, tachycardia, and hemoglobinuria in anesthetized patients. If suspected, stop the transfusion, verify compatibility, and run diagnostic tests. Management involves forced diuresis and monitoring for complications like DIC and AKI. The frequency is approximately 1 in 38,000 transfusions, with a fatal risk of 1 in 100,000. 2. Delayed hemolytic reaction, incidence, 1 in 12,000 transfusions. Mechanism, formation of antibodies to foreign red cell antigens after previous exposure. Symptoms, malaise, jaundice, fever 21 days post-transfusion. Complications, hemolysis, decreased hematocrit. Management, supportive, diagnosed with antiglobulin, Coombs test. B. Non-hemolytic transfusion reactions. 1. Febrile reactions, 1 to 3%. Temperature increase without hemolysis, treated with leukoreduction. 2. Urticarial reactions, 1%, hives, itching, and erythema, treated with antihistamines and steroids. 3. Anaphylactic reactions, A rare, occurring in approximately 150,000 transfusions, even after few mls of blood. B typically occur in LGA-deficient patients with anti-LGA antibodies who receive LGA-containing blood transfusions. C require immediate treatment with epinephrine, fluids, corticosteroids, and H1 and H2 blockers. D patients with LGA deficiency should receive special blood units, such as washed PRBCs, deglycerolized frozen red cells, or LGA-free blood units. 4. Transfusion-related acute lung injury. TRALI. A presence is acute hypoxia and non-cardiac pulmonary edema within 6 hours of blood product transfusion. B may occur with transfusion of any blood component, but especially platelets and FFP, with a frequency of approximately 1/5,000 transfused units. C. Treatment is similar to that for ARDS, but TRALI may resolve within a few days with supportive therapy. D. The incidence of TRALI has declined with the recognition that HLA antibodies in donor plasma are the principal risk factor, and this risk can be mitigated by selecting plasma and platelet donations from males or anti-HLA negative females. 5. Transfusion-associated circulatory overload (TACO). A occurs when blood products are administered too quickly, often during massive hemorrhage. Resuscitation, typically when resuscitation continued beyond hemorrhage control. B. Good communication between the resuscitation team and those controlling the hemorrhage is crucial. D. TACO is now the leading transfusion-related risk for trauma patients, surpassing TRALI. 6. Graft versus host disease. A occurs in immunocompromised patients when lymphocytes and transfused blood products react against the recipient. B. Leukocyte filters do not prevent this reaction, but irradiation of blood products eliminates lymphocytes. Infectious complications of blood transfusion. C. Infectious complications. 1. Viral infections, hepatitis B and C, can lead to chronic hepatitis, cirrhosis, and hepatocellular carcinoma, HIV, risk reduced due to testing, current risk approximately 1,900,000, CMV and EBV, usually mild, but severe in immunocompromised patients. 2. Bacterial infections, contamination risk, 1, 2000. Platelets, to 1,7,000 PRBCs, caused by donor bacteremia or inadequate phlebotomy and sepsis, can transmit syphilis, brucellosis, and other bacterial diseases. 112. Section II. Immunology. Immune responses, immunologic blood transfusion reactions, type, allergic anaphylactic, reaction, pathogenesis, IL lipersensitivity, reaction against plasma, proteins in transfused blood, IgA. Deficient individuals, ILD receive blood products without LGA, IL hypersensitivity, reaction, epiclecoices, intravascular hemolysis, ABO blood group, incompatibility, timin within minutes to 2-3 hours, due to release of profound inflammatory mediators in degranulating AST cells during transfusion or within 24 hours, due to profound antibodies, cynical presentation, allergies, urticaria, pruritus, anaphylaxis, wheezing, hypotension, respiratory arrest, shock, fever, hypotension, tachypnea, tachycardia, flank pain, lymoglobinuria, intravascular, jaundice, extravascular, fever, headaches, chills, flushing, more common in children, Denorblot 0D, host BL00D, Antiga, donor plasma proteins, including LGA, host mast cell, acute, hemolytic, transfusion, reaction, donor RBC with A and, or B group antigens, host anti-A, anti-BLGG, LOM, febrile, non-hemolytic transfusion, reaction, transfusion-related acute lung injury, toxins created by donor WBCs accumulate, curing storage of blood products, reactions prevented by co-reduction of blood products, ivohitnechinism, neutrophils are sequestered and primed in pulmonary vasculature due to recipient risk factors. Neutrophils are activated by a product, EG, and a leukocyte, antibodies in the transfused blood and release inflammatory mediators, T capillary permeability, pulmonary edema, anamnestic response to a foreign antigen on donor RBC and Rh, D, or other minor blood group.